the lecture for Pediatric Critical Care Nutrition. This lecture will focus on estimating nutrition needs for pediatric patients in the critical care setting. Nutrition goals for the Pediatric Intensive Care Unit focus on meeting energy requirements, so not too little energy and not too much energy for the state of inflammation that the patient is experiencing. I like to think of this as the Goldilocks phenomenon, and I'll be going into further detail. And also ameliorating protein catabolism. To review, total energy expenditure, as we've learned, consists of three components for adults: basal metabolic rate, thermic effect of food, and physical activity. For children, there's an added component of calories required to support growth. The RDA is used to estimate total energy expenditure for children less than 3, and the DRI estimates energy expenditure for children greater than 3. And these numbers are for a normal, healthy, growing child. As you can see, calorie needs per kilogram of body weight are much greater than the adult range of 25 to 35 calories per kilogram that we're used to. And this is because such a high amount of calories is needed to support growth, especially during the early years. So if we think about growth and the inflammatory process, we have to refer to growth as an anabolic process. The body utilizes calories to build tissues and grow. However, inflammation, acute stress, and trauma that a pediatric patient experiences in the critical care is a catabolic process. These two things cannot occur at the same time. So when a patient is in a state of catabolism, there's a transient absence of growth, and growth is halted during this time. Medical management in the pediatric ICU focuses on treating the underlying cause of the inflammation, and nutrition management focuses on supporting basal metabolic needs for organ function, monitoring the inflammatory state to adjust the nutrition goals accordingly, and liberalizing calories to support growth when the body is shifting into a state of anabolism. So first, we want to provide basal metabolic nutrition support. The gold standard to directly measure a patient's basal metabolic needs is using indirect calorimetry. However, because of cost and limitations of staff, most units, especially that aren't in research, do not have an indirect calorimetry machine. So in this case, we have to estimate metabolic needs using predictive equations. Predictive equations used for basal metabolic support for children 1 to 18 years old include the World Health Organization with no activity factor, and the equations based on age, male and female, are provided here. Other equations commonly used in the pediatric intensive care unit include Schofield and White equations. However, these are less commonly used because they do require the patient's height, and during critical states, it's often difficult to obtain the height because of the severity of illness for the patient. To estimate basal metabolic needs for patients 0 to 12 months, research and general consensus agrees that these children may require more than resting energy expenditure. It's unknown exactly how many more calories are needed for growth and essential brain development during this stage, so more research is needed to come up with predictive equations for this population. Currently, the consensus is to provide greater than resting energy expenditure for infants 0 to 12 months. So the World Health Organization equation, the Schofield equation, or White equation are all inappropriate for this age range. For 0 to 3 month old patients, we use an estimation of 80 calories per kilogram, and for 4 to 12 month old patients, we use an estimation of 65 calories per kilogram. I like to highlight this research study that compared pediatric ICU patient energy expenditure with measured energy expenditure, and that's the indirect calorimetry machine, versus calculated resting energy expenditure, and that's referring to the different estimation equations. So here at the bottom, you see that measured energy expenditure was slightly less than 1,000 for this population, and that consistently every estimation equation overestimated the energy that the patients needed. This includes the WHO and Schofield equation that I discussed on the previous slide. And you can see that they pretty closely estimate needs with each other, but both of them were almost 400 calories greater than the actual measured energy expenditure for these patients. So after you're providing basal metabolic support, it's important to monitor the acute inflammatory state and how the patient is progressing through their illness. The strongest inflammatory marker that we use at this time to measure the state of inflammation is CRP. A CRP of greater than 2 is associated with the state of catabolism, and a CRP less than 2 is associated with the state of anabolism. So this is a very delicate balance, and we like to monitor these values so we can understand how the patient's illness is recovering, but also how the patient's body is responding to calories in order to utilize them for growth or to utilize them for inflammation. So as a patient shifts from a state of catabolism to a state of anabolism, it's important to remeasure their energy expenditure with indirect calorimetry because it's changing as the body begins to utilize calories for growth. If indirect calorimetry is not available, this shift is occurring from using the World Health Organization or Schofield equations that estimate basal metabolic rate to equations like the RDA and the DRI that include calories for growth. So the Goldilocks phenomenon, as I was mentioning, refers to this balance of meeting the energy requirement and responding to the patient as they recover. So for example, if a patient's in a state of catabolism, their CRP is greater than 2, and the dietitian is providing increased calories to support growth, the body is not going to be able to utilize these calories, so it may result in overfeeding. On the flip side, if a patient's in a state of anabolism, if their CRP is less than 2 and they're able to utilize calories to support growth, but the dietitian decides to use an equation to only provide basal metabolic support, then this patient may experience risks of underfeeding. The pediatric malnutrition definition clearly has helped to identify risks with underfeeding patients and risks with pediatric malnutrition. However, it's important not to forget the complications that are associated with overfeeding. And in the pediatric intensive care unit, complications of overfeeding in the acute phase can actually outweigh complications that we see with underfeeding. Some risks include impairing liver function, causing cholestasis, also increasing infection risk due to hyperglycemia, and even prolonging mechanical ventilation for our intubated patients because CO2 production is increased during overfeeding. All of these risks can further increase the patient's length of stay in the PICU, but also their length of stay in the hospital and hospital costs. Furthermore, research has not shown an added benefit to the maintenance of lean body mass when calories are increased. So for this reason, it's really important that we ameliorate protein catabolism during the ICU. Children have less reserves than their adult counterparts. In my reference to reserves, I'm mainly speaking about their lean muscle tissue. They have less skeletal muscle, so when the body is turning to protein stores to break down during inflammation, the pediatric patient experiences a higher breakdown of organ muscle tissue. This inadequate protein stores has greater consequences for the pediatric patient in the inflammatory state. We see a higher incidence of longer mechanical ventilation days, greater infection risk, and greater length of stay for pediatric patients that do not receive enough protein during their inflammatory state. So for that reason, the American Society for Parenteral and Enteral Nutrition recommends critical care protein needs of 1.5 to 2 times the RDA. So for patients 0 to 1 year of age, we see protein of up to 3 grams per kilogram per day. And for children 1 to 13 years old, we see 1.5 to 2 grams per kilogram per day, and up to 1.5 grams per kilogram per day for the adolescent young adult child. So when we think about nutrition support in the pediatric intensive care unit, especially during the inflammatory state, I mainly refer to this as hypocaloric and high protein feeds. Hypocaloric because we're eliminating the factor of growth, and high protein because protein needs are almost doubled during this time. Just like for the adult patient, we want to monitor and evaluate nutrition outcome measures in order to determine if our nutrition support plan is working. Two nutrition outcome measures that are very important in the pediatric ICU population are nitrogen balance studies and mid-upper arm circumference. For nitrogen balance studies, 24-hour urine collection as well as a 24-hour dietary recall can allow us to calculate urinary urea nitrogen and daily protein intake in order to determine the patient's nitrogen balance. This helps to evaluate if our protein prescription is adequate, and if a patient's in negative nitrogen balance, it's supported that more than 3 grams per kilogram per day of protein can be provided, up to 4 to 4.5 grams per kilogram per day. Mid-upper arm circumference is another important nutrition outcome measure. A decrease in mid-upper arm circumference indicates a direct decrease in lean muscle mass. This also is a protein marker. If a patient has experienced a decrease in lean body mass, they likely have inadequate protein, but it can also be beneficial to reevaluate the energy needs to make sure too little energy is not being provided in addition to too little protein.